Critical Thinking and Coding Tips for Chapter 25. Okay, our first critical thinking question. Can complications be coded as principal and/or secondary diagnosis? And our answer is yes. Complications can be coded as either principal or secondary diagnosis. If a patient is in the hospital and has surgery performed and then develops a postoperative fever, the principal diagnosis would be the indication for the surgery, and the secondary diagnosis would be the postoperative fever, 998.89 and 780.6 respectively. However, if a patient has surgery and is discharged home and then returns with a fever, the principal diagnosis would be the postoperative fever, which is 998.89, with 780.6 as a secondary diagnosis. It's important to keep the following in mind. If a patient comes into the hospital with a complication, the complication code must be sequenced as the principal diagnosis, with the secondary diagnosis further describing the complication. Now our second question, what is the difference between coding 996.0X, which is mechanical complication of coronary bypass graft, and 414.02 and 414.03? And our answer, if the bypass graft becomes occluded, 996.0 should be coded. Another term that might be used is delayed closure of bypass graft. Now, if the bypass graft is documented as atherosclerosis, which is a chronic progressive narrowing and blocking of the coronary arteries, then 414.0X is the correct code to use. Once again, the correct code is determined by the documentation in the medical record. Okay, and our last critical thinking question, how is a patient admitted with line sepsis coded? And our answer, line sepsis is an infection of the blood caused by a vascular catheter. If the patient is admitted with sepsis and the cause is determined to be the vascular catheter, such as a PICC line, then the principal diagnosis must be the complication code. It's tempting to code the sepsis as the principal diagnosis because the MSDRG typically pays better with sepsis as the principal versus the complication code. However, in this situation, that would be considered upcoding. The complication code must be sequenced first because it is the cause of the sepsis. Typically, the catheter would be removed and/or replaced in order to remove the cause of the infection. Okay, here are some coding tips now for this chapter. Now, the importance of identifying whether a condition is a complication or simply an expected outcome. The words intragenetic and nosocomial indicate adverse effects and can poorly reflect on a hospital and/or physician. The documentation must be clear, and if there is any confusion, it's best to query the physician. Just because a condition occurs after surgery, it does not make it a complication, and the documentation must support the code. At the same time, these codes can be beneficial to hospital administration and can become a tool to identify opportunities to address quality of care issues that might occur in a facility. Next, how to determine whether to code an additional code after a complication code. Now, if the specific condition is included in the complication code description, then no additional code is necessary to add detail. However, if the complication code is vague or describes a body system only, then an additional code is used to add the detail. For example, 997.91 is postoperative hypertension and does not need an additional code to describe the condition. In the case of postoperative pneumonia, the codes used would be 997.3, which is respiratory complication, and 486, which is pneumonia, because 997.3 does not describe the specific complication, only that the body site involved. Okay, continuing on, how postoperative pain is coded. There is no complication code in categories 996 through 999 to use for postoperative pain. Postoperative pain is assigned to the code that describes the pain by the specified site, such as abdominal pain, which would be 789.XX. The difference between a hematoma and a hemorrhage as they relate to complications. Now, a hemorrhage is a current bleed or an escape of blood from an intravascular space. A hematoma is a localized mass of blood that is usually confined. It typically occurs after a bleed and when the blood is clotted or partially clotted. It's found under the skin and is not associated with an open wound. Now, the use of V codes with complication codes. If a complication of a coronary artery bypass graft or CABG is coded, do not use the V code for status post-CABG. The complication code explains that the patient had a CABG, so no V code is necessary. Now, how to select the correct complication code when more than one seems to fit the scenario. For example, postoperative UTI seems as though it could be coded as either 997.5 as urinary complication or 998.59 other postoperative complication. In this instance, if you know the site and/or organ that has the complication, code to the specified site because it's more specific. In this case, 997.5 would be used because it identifies the complication as urinary versus unspecified. An additional code of 599.0 would be used to describe the complication as a UTI. And finally, the use of other complication codes. Now, mechanical complications include breakdown, displacement, leakage, obstruction, protrusion of implant, and infection and/or inflammatory complications. These are rather straightforward when it comes to decision making. Other complication codes would include pain, thrombus, embolism, hemorrhage, and stenosis attributable to a device or implant. Now refer to the beginning of 996.7x in the ICD-9-CM code book for a list of what is included in this group of codes. Now review these complication codes and determine what V codes would be appropriate to code. 996.81 and V42.0. For this group, you do not code V42.0, which is transplant kidney, because it's described in the code 996.81. In the set of codes 996.66 and V43.65, you would code both because the code 996.66 specifies only joint and code V43.65 indicates the specific joint as the knee.